Intravenous fluids and post-operative fluid management. Fluid balance is the relationship between fluid output and fluid intake. Under normal circumstances, fluid balance is maintained quite precisely, but in the surgical patient, it has to be monitored carefully. Fluid loss occurs in the following ways: 1,500 ml in urinary excretion, 900 ml in insensible loss, 100 ml in feces, and in a total of 2,500 ml per day, while a normal daily requirement for an adult is as follows: 2,500 ml in water, 100 to 180 milliequivalents per 24-hour in sodium, 40 to 60 milliequivalents per 24 hours in potassium, while 100 grams in glucose. Post-operative fluid management. Practical fluid balance for the operated patient. The calculation is based on the initial estimated loss, the maintenance requirement, and the ongoing loss. And for the ongoing loss, usually 50% of the calculated loss is corrected in the initial 24 hours. For the initial estimated loss, all perioperative losses are isotonic and should be replaced by isotonic fluids, and all such losses must be rectified. Blood loss in excess of 15% of the blood volume in the adult is replaced by infusion and stored blood. Lastly, smaller blood losses may be replaced by crystalloid solutions. Maintenance requirement is estimated after all the operative losses have been calculated and dealt with. This is based on the estimated normal requirements of the patient. For example, a normothermic 60 kg adult with a normal metabolic rate will require about 2,000 ml of water, 100 milliequivalents of sodium, and about 50 milliequivalents of potassium per day. Thus, this patient requires a daily fluid maintenance under uncomplicated circumstances consisting of 1,500 ml of isotonic water as 5% dextrose, 500 ml of 0.9% normal saline, and 60 milliequivalents of potassium. But certain modifications have to be made in the first 24 hours, when stress response to surgery is the maximum as stress. This induced release of ADH, aldosterone, and cortisol causes retention of sodium and water, and increased renal excretion of potassium. Endogenous release of potassium from traumatized tissues, and catabolism warrants restriction of potassium. Therefore, in the first 24 hours, the patient requires no salt and less of water than normal. 2,000 ml of 5% dextrose is sufficient when all the operative losses have been replaced. By the second 24 hours, metabolic response diminishes. Patient requires 2,000 ml of 5% dextrose and 1,000 ml of isotonic saline in 24 hours. From the third post-operative day and thereafter, 20 milliequivalents of potassium is added to each 500 ml of intravenous fluid to give a total of 60 milliequivalents in 24 hours. Additional fluid may be required in the following circumstances: if blood or serum is lost through drains, if GIT losses continue, continuing third space losses in the first 24 to 48 hours after major surgery, during rewarming if the patient has become hypothermic during surgery, these losses are replaced as isotonic saline, and in lower intestinal losses, ringer lactate is preferred. For every 1,000 ml of fluid loss, 20 milliequivalents of potassium is added. For example, a post-operative patient has a Ryle's tube aspirate of 1000 ml, a biliary fistula of 1000 ml, and a urinary output of 1000 ml. If the patient is not dehydrated, fluid calculation will be thus total fluid requirement is 1000 added to 1000, then added to 1000, then added to 500, and in a total of 3500 ml. To calculate the total fluid required for this patient in a day, including maintenance, for saline required, ongoing losses of bile and gastric aspirate is replaced as NS. 2000 ml of 0.9% normal saline, maintenance requirement of saline is equals to 1000 ml in a total of 3000 ml. Potassium required for ongoing losses is equals to 40 milliequivalents. For maintenance, 60 milliequivalents in a total of 100 milliequivalents. There is a minimum of 100 grams in glucose required. Hence, this patient's total requirement of 3500 ml can be administered as the following: 1500 ml of 0.9% NS, 1500 ml of TNS, 500 ml of 5% dextrose, and 100 milliequivalents of potassium. Assessment of adequacy of fluid and electrolyte replacement. First is clinical and biochemical parameters. This consists of general condition and sensorium, signs of dehydration, hemodynamic stability, vital signs, pulse, also blood pressure, and it is also consists of hematocrit, serum electrolytes, and urine osmolality. Second is urine output. It is a very sensitive index, and the ultimate goal of hydration is to obtain a minimum urine output of 0.5 ml per kilogram per hour. Lastly is the CVP. Normal level is 4 to 8 centimeter of water, which provides realistic information about fluid volume. CVP should be monitored half-hourly, should be evaluated in the background of other data like pulse, blood pressure, respiration, and, for example, an increase in CVP parallels an increase in systolic blood pressure indicating adequate fluid volume replacement. After major surgery, assessment of fluid and electrolytes is best achieved by the measurement of urine output, CVP, and serum electrolyte concentration. Judicious and appropriate administration of fluids in the post-operative period will be reduced morbidity and mortality. The following points should be always borne in mind with regard to intravenous fluid therapy. First is the replacement fluids. These are used to replace abnormal losses of blood, plasma, or other extracellular fluids. In treatment of patients with established hypovolemia, example is hemorrhagic shock, then maintenance of normal volemia in patients with ongoing fluid losses, example is surgical blood loss. Second, intravenous replacement fluids, and these are the first line treatment for hypovolemia. Initial treatment with these fluids may be life-saving and provide some time to control bleeding and obtain blood for transfusion if it becomes necessary. Third is the crystalloid maintenance fluids, which contain dextrose and are not suitable for use as replacement fluids, only crystalloid solutions with a similar concentration of sodium to plasma. and are effective as replacement fluids. This should be available in all hospitals where intravenous replacement fluids are used. Fourth is crystalloid replacement fluids, and also should be infused in a volume at least 3 times to the volume loss in order to correct hypovolemia. Fifth, all colloid solution like albumin, dextrans, gelatins, and hydrocephyl starch solutions are replacement fluids. However, they have not been shown to superior to crystalloids in resuscitation. 6 is colloid solution should be infused in a volume equal to the blood volume deficit. 7. Plasma should never be used as a replacement fluid. 8. Plain water should never be infused intravenously because it will cause hemolysis and will probably be fatal. Lastly, in addition to the intravenous route, the intraosseous, oral, rectal, or subcutaneous routes can be used for the administration of fluids. Replacement fluids. Replacement fluids are used to replace abnormal losses of blood or other extracellular fluids by increasing the volume of compartment. There is sometimes also called plasma substitutes. Replacement fluids are used principally in treatment of patients with established hypovolemia or hemorrhagic shock, maintenance of normovolemia in patients with ongoing fluid losses, for example, surgical blood loss. And all solutions are replacement fluids. However, only crystalloid solutions that contain a sodium concentration similar to plasma are suitable as replacement fluids. Some of these crystalloids have a composition resembling extracellular fluid and are known as balanced salt solutions. For example, is Ringer's lactate or Hartmann solution. Examples of replacement fluids are the following: crystalloids with a similar concentration of sodium to plasma, like normal saline, Ringer's lactate, and Hartmann solution. And also all colloid solutions are examples of replacement fluids. Intravenous replacement therapy. In hypovolemia, the primary goal of treatment is to restore the circulating blood volume in order to maintain tissue perfusion and oxygenation. The administration of replacement fluids achieves this by increasing the volume of the vascular compartment. A blood transfusion may also become necessary if there is extensive blood loss. However, even in cases of severe hemorrhage, initial treatment with intravenous replacement fluids may be life-saving and will allow time to obtain blood for transfusion. Intravenous replacement fluids are the first-line treatment for hypovolemia.
Intravenous replacement fluids. First, we have crystalloids. Crystalloids are composed of crystalline substances such as dextrose or sodium chloride, which, when dissolved in water, form a clear solution of electrolytes or sugars. Crystalloid replacement fluids can contain a similar concentration of sodium to that of plasma. This ensures that they are excluded from intracellular compartment since the cell membrane is generally impermeable to sodium. It is always important the crystalloid should be infused in the volume at least 3 times the blood volume deficit in order to correct hypovolemia. When large volume of crystalloid fluid are administered, edema develop as a result of a fluid that passes from the circulation into the interstitial compartment. A careful monitoring of a patient's clinical condition is therefore essential. Crystalloid maintenance of fluids which contain mainly dextrose are not recommended for use as a replacement fluid. Dextrose glucose solution do not contain sodium and are poor replacement fluids. Do not use them to treat hypovolemia unless there is no other alternative. Here in the table shows the suitability of intravenous fluids as either maintenance or replacement fluids. Colloids. Colloids are composed of suspension of particles that have a much larger molecular weight than crystalloids. These particles are generally too big to pass through the capillary membrane and initially tend to remain within the vascular compartment. They are used as replacement fluids. Example given are the gelatins, dextrans, hydroxyethyl starch. The effect of these particles in the circulation is to mimic plasma proteins, thereby maintaining or raising the colloid osmotic pressure of a blood. The molecular weight and the number of particles in a colloid solution is important in determining its properties. The larger the particle sizes, the longer the durations of action of the solution in the vascular compartment. Also, the higher the number of particles in the solution, the greater the osmotic effect. Colloids can be classified as plasma-derived or natural and synthetic. Plasma-derived natural are prepared from donated human blood or plasma, such as your albumin. These should not be used simply as replacement fluid. Synthetic. Synthetic are prepared from another source. Example given are your bovine cartilage, gelatins, dextran 60 and dextran 70, hydroxyethyl starch, and pentastarch. Colloids require smaller infusion volume than crystalloids. Also, the higher the number of particles in the solution, the greater the osmotic effect. In many conditions where the capillary permeability is increased, they may leak out of the circulation and produce only a short-lived volume. Supplementary infusions will be necessary to maintain blood in the conditions such as trauma, acute and chronic sepsis, burns, and snakebite. The properties of ideal intravenous replacement fluids should be easily available and inexpensive, non-toxic, free of allergic reactions and risk of infection, as well as totally metabolized or eliminated from the body. The crystalloids or colloids controversy. Most clinicians agree that in hypovolemic patients, it is essential to restore blood volume with replacement fluids. However, they disagree on the type of fluid that should be used. Both crystalloids and colloids have advantages and disadvantages as shown on this table. The advantages of crystalloids: few side effects, low cost, and wide availability. The disadvantage are short duration of action and may cause edema. Advantages of colloids: they have longer duration of action, less fluid required to correct hypovolemia. And the disadvantages are they have no evidence that they are more clinically effective, higher cost, may cause volume overload, may interfere with clotting, and risk of anaphylactic reaction. Don't forget, if a supply of infusion fluid is limited, it is recommended that, wherever possible, the crystalloid, normal saline, or a balanced salt solution such as Ringer's lactate or Hartmann's solution should be available in all hospitals where intravenous replacement fluids are used. Before giving any intravenous infusion, we should always check the seal of the infusion fluid bottle or bag is not broken, check the expiry date, as well as check the solution is clear and free from visible particles. Plasma-derived colloids. These are prepared from donated blood or plasma. They include plasma, fresh frozen plasma, liquid plasma, freeze-dried plasma, and albumin. These products should not be used simply as replacement fluids because they can carry a similar risk of transmitting infections such as HIV and hepatitis as a whole blood. They are also generally more expensive than crystalloid or synthetic colloid fluids. On this table shows the composition of replacement fluids and plasma. Factors affected by acid-base imbalance. The following four clinical entities can occur: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. That would be all. Thank you.